Good morning, good afternoon, good evening, everyone. My name is Sivesh. I'm currently a surgical trainee based in Birmingham, and thanks for the invite to present on our Chyle Delphi, which is an international consensus statement. I have no disclosures, and so does my other authors. So Chyle following esophagectomy for malignancies are relatively uncommon. They can range with an incidence about 1% to 9%. And the underlying pathophysiology for these are often quite complex and unwieldy. The clinical impact of Chyle is also quite substantial, associated with morbidity of up to 50% and mortality up to about 10%. And in patients with Chyle, they have associated increased hospital costs and potentially reduced long-term survival. And although they have increased morbidity and mortality, the diagnosis and management of these patients remain controversial. They remain a challenge globally. There have been several reviews published on Chyle, but none have provided a clear recommendation for management in clinical practice. So we therefore decided to take an international modified Delphi consensus methodology amongst a group of international esophageal surgeons, aiming to identify preoperative risk factors, intraoperative techniques, methods of postoperative diagnosis and management of Chyle after esophagectomy. This was a five-stage process, starting off with a scoping review, data analysis using the OesophagoGastric Anastomosis Audit, and 2 rounds of voting, analysis of results, with subsequent development of recommendations. So stage 1 was evidence-based mapping, where we undertook a systematic review, which included 63 studies, which included 28,860 patients. Majority of these were retrospective cohort studies, and the overall Chyle rates reported was 3.4%. And this is a summary slide showing all the reported Chyle rates across all the included studies. We then subsequently evaluated the literature of all these 63 studies to assess the primary, secondary, and tertiary management where available of patients who developed Chyle in the series. So there were of the 28,000 patients that were included, we had 1,000 patients where data were available for management of patients who developed Chyle. And of patients who had primary management, almost majority of them, almost 92% of these patients had non-operative management. And some of these included conservative, MCT diets, TPN. However, it's important to note that of patients who had non-operative management, almost 50%, almost close to 50% only had a success. However, contrary to that, in patients who had operative management, when you look at thoracotomy, thoracoscopy, transabdominal approach, almost 75 out of 77 patients had a clinical success. And as it went on, patients had secondary and tertiary management, where operative approaches were more successful than the non-operative management for patients who developed Chyle. Once we found out what the scope of the literature was, we then went to the OesophagoGastric Anastomosis Audit data, which we had 2,247 patients, of which 5.4% had a Chyle. Of those that developed a Chyle, 21% had type 2 Chyle, and almost 44 patients had type 3 Chyle. We then stratified the data by the grade of Chyle and associated complications. Patients who had higher Chyle were more likely to have a significantly longer length of stay in hospitals, lower rates of eating on discharge, significantly higher rates of 30-day admission, and 90-day mortality. We then conducted a Delphi voting. Once we understood the burden of the disease and what was available in terms of management, we conducted Delphi voting across all these 4 domains. And in the first round, there was 275 surgeons, and the next round, there were 250 surgeons, and these were across 45 countries. And these gave us a true representation of the volume of, and the breadth and variety of reporting that we would get across the world. However, only 10 surgeons, i.e. 4% of the population, were from high-volume surgeons, and 12, i.e. 4.4%, were from high-volume departments. So they're relatively low volume. And this slide demonstrates the consensus across round 2. And the green column represents consensus more than 80%, i.e. more than 80% of surgeons agree with these risk factors. The yellow represents 70 to 80%, and red represents 60 to 70%. And where they were unshaded, there were no consensus gain. So as you can see, patients, there was a broad consensus for minimally invasive esophagectomy or lymphadenectomy being a risk factor for development of Chyle leaks. And also patients, all these surgeons felt that routine thoracic duct ligation should be routine, and the methods of ligating these thoracic ducts should be with sutures instead of alternating metal clips, plastic clips, or ligature. And when we split them by surgeon specialty or surgeon volume, we see broad consensus in these agreed domains. We then went on to look at the postoperative diagnosis, severity, and management of Chyle leaks. And as you can see, there was broad consensus in what we define of a diagnosis of Chyle leaks. So for instance, a milky chest drain output, which we all know quite well, but there's also broad consensus to suggest that confirmation with triglycerides or presence of chylomicrons is also important in the diagnosis of Chyle leaks. In terms of how we define severity in the systematic review, we identify broad domains of how people diagnose severity, and with varying volumes. So we then took these international surgeons to ask what would we define, and volume of chest drain output defines severity along with total duration of Chyle leak. In terms of management, there's consensus of a step-up approach and using non-operative methods in the first instance prior to operative treatment. So we then went back to the group of surgeons and we had meetings where we could then ask these surgeons questions and present to them back the data from the Delphi voting, but also the OGAA data and the systematic reviews. And we came up with these 6 broad recommendations for management of Chyle leaks that will help surgeons not only in high volume centers, but also globally for those practicing esophagectomy. So for instance, then it should be risk stratification to identify high-risk patients. Routine ligation thoracic ducts recommended. And in terms of diagnosis of Chyle leaks, excess volume of more than 500 ml within 24 hours should be diagnostic, along with the milky chest drain, presence of triglycerides more than 1.1 millimole per liter, and presence of chylomicrons in the chest drain fluid. Severity should be assessed with the volume of chest drain output and or total duration of Chyle leaks. A step-up approach is recommended in the management of patients with Chyle leaks, and operative management should be considered once non-operative options have not been successful, and these should be recognized early on so that we can intervene sooner. We then came out with this flow diagram to help surgeons with guiding clinical practice. So you have diagnosis of Chyle leaks, which we've explained. And once you diagnose Chyle leaks, there should be immediate initial management by stopping enteral feeding, accurate mounting of chest drain output, and electrolyte balance. Thereafter, you should have a volume assessment in 24 hours. And based on these volumes, you should then stratify your treatment based on MCT, TPN, or if you really have high volume output in 24 hours, operative intervention should be favored, i.e. lymphangiography plus minus embolization, if not available to proceed surgery, or thoracotomy or thoracoscopy. So this algorithm helps provide surgeons globally with standardizing management of Chyle leaks to allow improvement in patient outcomes. So in summary, there's several areas of consensus reached surrounding diagnosis and management of Chyle leaks following esophagectomy for malignancy, and guidance in clinical practice to adaptation of recommendations from this consensus may help in the prevention of timely diagnosis and management of Chyle leaks. I'd like to thank all the authors involved in this cohort study. Thank you very much. And I'll take any questions thereafter.